Hey everyone, it's good to talk to you again. It's been 2 weeks already, which is pretty wild. Actually, it kind of has flown by, even though the days can be kind of long. But yeah, it's been 2 more weeks, and I've kind of more officially, I would say, started residency, where actually seeing patients, actually starting to. We're still sort of in the orientation. Mode, but definitely starting to kick it up a few gears. And I had the first week and a half, a little over, on the Psych Inpatient unit here at the VA. So that was a brand new experience for me, and one that's been pretty interesting to better understand. And so I figured I would kind of take you through a typical day of working from a resident standpoint on the psychiatric unit. Our unit has 11 beds total, so we can have up to 11 patients. I think while I was there with my co-resident, I think 6 was the highest that we had at one time, but it can get up to 11. Just depends on what's going on. But yeah, so essentially my day starts pretty early. I usually get there around 7. And you have some time to essentially look at the patients that you're over. Just kind of during this week and a half orientation, I split the patients with my co-residents, so that was kind of nice. So usually I would just have like 2 or 3 patients, so not very many, but definitely enough for me to keep me busy. But I'd get there around 7, and I go right to the computer, and I would log into the EMR system, which we use CPRS, which is a very old, outdated system that is still utilized by the VA. So it just kind of is what it is. But so a lot of acquainting myself with that system. But that's the first thing I do is I log into the EMR, the electronic medical record, and look at the nurse's note overnight. So I see kind of what's been going on overnight. Is there anything that I should be aware of? Usually the nurses will put in a paragraph at the bottom of their behavioral assessment for a psych patient on how they're doing, if they needed to give them any PRN or as needed medication for typically agitation or a behavioral concern. That can be really helpful to know kind of what your patient was doing last night or last evening. It's also they I'll say this, they also put how much the patient sleeps, which as a former CNA who also had to report how much sleep the patients got, I know that that's a guess. Because because it's impossible to know how much your patient sleeps, but it is a part of it. So it always makes you chuckle, because it's kind of like respirations, like, which are part of the vital signs. There's a lot of people that kind of waffle that number and are kind of like, yeah, you're not breathing too fast, you're not breathing too slow, you're probably breathing in a normal range between like 14 and 18, so let's call it 16. And no one's going to question you if you say respirations are 16. And I feel like sleep's kind of similar in these notes. Like, I swear every patient that I have is always getting 6.5 hours of sleep. And you're just like, yeah, whether they are or not, it's who knows, but that's always something that kind of makes me laugh a little bit. But I look at the nurse's note, which is helpful in a lot of ways. So look at that first, and that usually takes me a little bit. And then the next part of your day is actually seeing the patient, and I usually see a patient around 8:30, kind of depends on how long I spend kind of getting things set up for the day, or if I wanted to look or read something else. I also don't want to go too early, because seeing people really early, sometimes they're still sleeping, and so I try to kind of like do 8:30 is kind of when I start making it on the unit to actually talk to folks, hoping that they're awake. If they're not awake by then, I don't wake them up. I'll just see them later in group rounds. But usually between like 8 and 9 is when I try to see the patients, and essentially you're seeing how the night went, you're seeing how they're feeling today. Usually you've made a medication change, not always, but oftentimes the previous day. And so it's kind of an opportunity for you to really quickly in the morning say, how are you feeling on the new, whether we increased a dose of their nighttime med or introduced a new medication, just to kind of say, like, how is that working for you? Are there any side effects from it? A lot of the meds that we give are sedating, or can be, and so sometimes they will have a decent amount of fatigue, and so just things to be aware of and things to kind of explore with the patient and how they're feeling on the different meds. So yeah, you check in with your patient, you kind of get a brief snapshot of how they're doing for the day, and then at 9 o'clock we meet together as an interdisciplinary team. So this includes me as a resident. Med students are there because it's a teaching hospital at the VA, and so a lot of University of Washington medical students do their rotations here, which is cool. And so we had 2 medical students that were doing their psychiatry rotation, so they're a part of the team, and they actually help me see patients, which is great. And so the med students are there, residents there are attending. Who are attending is Dr. Z, and so she does pretty much exclusively inpatient psych, and she's awesome. I really like her. I think she does a really good job of, just triaging, which essentially means kind of evaluating cuteness of a patient, and she's just really good at being able to get a good feel of what do I need to do for this patient. Which is a great skill for inpatient and outpatient, but especially inpatient, I'd say. So anyway, 9 o'clock comes, interdisciplinary team. So it's the med students, it's the residents, it's the attending, it's also the nursing staff. Usually, we have a medical designated nurse practitioner on the floor that is just there to manage medical comorbidities or other medical problems that the patient is having that we are not totally overseeing. She will take care of, so let's say that the patient is diabetic or something like that. We aren't really managing their insulin or their other non-psychiatric medications. That's kind of deferred to her. But she's a part of the team to address kind of medical concerns, and then we also have usually social work, psychology, team, and peer support will oftentimes be there as well. So and during this meeting we go through every single patient that's on the floor, and if it's my patient or if it's my co-resident's patient, we'll kind of present really briefly why they're here, what's going on, what's the treatment plan, what are kind of the goals for the day, or what are we doing with the patient essentially. And then we kind of do a round robin, kind of go around the table, and if anyone has more to add, or questions, or an ongoing discussion that we need to have about maybe a patient's medication, or just stuff. So it's a cool opportunity. Usually that meeting will last about a half hour, sometimes up to an hour, depending on how many patients we have. So usually that's 9 to 10. Around 10 to noon or so is when we typically start to, as a group of my attending, us as the residents and the medical students, we do our rounds. So it's where all of us meet with the patient together. So there can be a lot of people in the room, and that can be kind of uncomfortable for the patient, but it's something that is just part of teaching, as far as from a resident standpoint and also from a med student standpoint, and that they're always aware of. And so, but it's a cool opportunity to all of us get to lay eyes and be in the same interview, and so we all get to kind of talk about it after the fact and discuss the patient, and we all know kind of what's going on. Which is pretty cool. So even if it's not my patient that I'm interviewing, there's still a lot of value in just watching other people discuss or do an interview, and just kind of listening to the med students, as they go through their psychiatric interviewing. So that usually goes until about noon, is usually when we stop. And then it's no writing time. So then we pretty much just write our notes for the early afternoon. That can take, at least for me, takes a lot of time, which is silly because no one's ever going to read. Well, someone will, kind of, but probably not, honestly. Like, when it comes to inpatient, like, you're doing what's called a progress note, which is essentially like a quick little snippet of, like, what are we doing today? How's the patient doing today? Because since they are in the hospital and we are seeing them every single day, we don't need to keep repeating a lot of kind of extra information. So it's really kind of just, how's the patient doing today? Are we making a change to their medication regimen? Or what are we doing to either diagnose something that was maybe unclear when they first presented? So maybe we're still trying to clarify a diagnosis like schizoaffective disorder, or an unspecified mood disorder, or a substance-induced mood disorder, or something like that. Or usually it's a medication change. And so it's like, hey, this is what we're doing. This is how the patient's doing right now. Here's the labs that we need to run, or here's what we need to check. So the notes themselves don't take a crazy amount of time, but they do for me because I'm trying to be thorough and complete, and my attending's reading them, and you want to do good. But it is kind of funny when I think about it because no one really reads. Like, if someone does look up a patient that you're seeing, like in the future, they really won't probably be reading your progress notes at all. They'll just read the discharge summary of the patient. So really, that's the most important note, because that will summarize essentially their entire hospital stay. No one, like, from a outside physician standpoint, is probably going to be like, oh, what's the progress note on this date? Like, who cares? It's like, what happened to the patient throughout the course of their stay? So from that standpoint, I kind of, you're just trying to be complete, but also not, like, I don't know, go too overboard into the details, because it's kind of wasting your time just a little bit. But I don't know, it's just kind of the nuance of progress notes in inpatient medicine. But that's usually what we do from like 12 to, I'd say like 2-ish or so. Probably takes me a couple hours and I'm usually doing other things too. So like by the time I actually finish it, it's probably around there. And then, as part of the inpatient service, we also essentially field people that are being considered for placement on the inpatient unit. And so this could be people that are on the medical floor. So maybe they have a new psychiatric concern that the medical team is like, hey, let's consult psychiatry, like some new symptoms that seems out of the ordinary for this individual, and there's concerns. Let's get a consult. So we actually have a consult psychiatry, which is really what I'm doing like this upcoming week, actually, is being a part of that service, where they will go into the hospital on the floor, so like the medical floor, not the psych unit, but the medical floor, and evaluate a patient. In order to be admitted to the psych unit, they have to meet pretty strict criteria. Like there's a kind of a screening that we do. So one of the screenings is that they really can't have any really serious medical condition that we're acutely managing, just because we don't have the resources up in the psych unit to be able to, like, for example, if they needed an IV, our patients don't have IVs, mainly because it's a safety concern, but other reasons as well, like a ventilator if someone was having, like, all of those types of things. So anything that requires more intensive care really isn't suitable for our inpatient unit, at least. If it was psych ICU, things are a little bit different. But at least for our unit, for example, our nursing staff is not able to administer like involuntary medications. So like the classic like IM shot for an acutely agitated patient that's getting very aggressive. Like there might be some very extreme situation where we might be able to do something like that, but it's not something that our unit is built for. So that's something that we kind of screen for. There's more appropriate facilities in the Treasure Valley through St. Alphonsus, which is a sister system that's just better resourced and better equipped to handle that kind of a patient. So they really can't be really acutely agitated to the point where they think we would need to actually sedate them or something like that, kind of give them a medication to calm them down. That's a really like serious threat to someone else or to a staff member or something like that. They can't be medically too complex. They have to be pretty stable medically. And so all of that kind of goes into the consult piece. But if they do meet that criteria and they have significant psychiatric concerns that really would be best suited for inpatient care, usually that is something along the lines of there's a safety concern to the patient's self or to someone else from the patient, or they are gravely disabled secondary to their psychiatric illness. And so by not having them here, they kind of become a risk to themselves. They're unable to take care of themselves appropriately. So yeah, those are all reasons why they would go to the psych unit, so long as they are medically cleared. And again, there's kind of some other like behavioral and agitation screening that also takes place to make sure that they're suitable for the unit. But that typically comes in the afternoon as well. And then we do sign out, which is around 4 o'clock-ish for me. It's where I have a chance to present our patients, or the patients that I'm taking over, to the on-call resident for the night. So they kind of take over for the rest of the evening, and then by the time we get back the next morning, they are the resident that is in charge, and they're on call. So if there's a medication issue or there's something that they need to address, they will take care of it. But sign out is an opportunity for us to tell them about the patients, and a lot of times you're just repeating yourself because it's like the same on-call person, and so they know the patients, so it does get quicker. But if it's a new patient to the on-call person or whatnot, sometimes it can take a little bit of time just to go over. But really, like when it comes down to like what do you need to tell them to just take care of someone overnight, it's why they're there. Did you make a medication change today? Do they have any medications that are available to them that are like as needed? So let's say like hydroxyzine is a common one that we give for anxiety. So if they're on that, they'll ask you questions like if the patient gets anxious, or if the patient becomes agitated, is there something that I can give to the patient that's already ordered? So those are the types of questions that you're kind of wanting to think about as you're giving sign out. But yeah, and then once you've signed out for the day, you are done, which is kind of nice. So I don't know, inpatient, I've always been an outpatient fan. That's my main exposure to psych, but inpatient, I can kind of see why there's an appeal to it. I mean, you show up early, but you kind of get your stuff done early in the morning. The afternoon can be busy, but oftentimes is pretty chill. It's not too bad unless it's just a crazy day, which does happen. But oftentimes feels pretty manageable, and then you sign out and you're done for the day. So you don't have to come back in. There is an on-call resident and attending that are basically in charge from 4 o'clock to 7 in the morning tomorrow. So yeah, so that's a day, and I did that for like the last week and a half. Has kind of been my life on repeat. So one last thing that I'll say before I let you go, because I find it really interesting, is what's called a involuntary hold for a patient, or I just call it a hold. or that's what we call it. Is the patient on a hold or are they not on a hold? A patient is put on a hold when they do not want to voluntarily stay in the hospital, but they are either in a position where they are an acute danger to themselves or to someone else, or again, are gravely disabled by their condition. So they just can't make that decision. And it's a judgment call. Like, that gets somewhat gray. But you as a physician, also police officers, and there's also several other, like, I think psychologists, and I think there's quite a few individuals. It's not exclusive to physicians, but they can place essentially a hold on a patient. So let's say you're seeing someone and you're talking with them and you're kind of like, okay, like, is this someone that, needs to be in the hospital? Is this someone that needs to be more outpatient? And then they say something that really raises a red flag. Maybe they have a plan to hurt themselves or something to that effect. They start telling you that they have means to do it. Now there's lots of red flags that are popping up. And if they say, like, yeah, I'm not staying here, I'm going back home, you can place a hold on that patient. And it's actually a legal, so there's a piece of paper, and I haven't had to do this yet, but it's coming in my future for sure. Piece of paper, you have to document everything, why you feel like this person is a danger or in danger, and why you're placing them on hold. And then you send that information out to the state. So that goes to the Department of Welfare, and they have 24 hours from when you file a hold on a patient to send what's called a DE, or a designated examiner. And this is someone who's designated by the Department of Welfare to come in within 24 hours and evaluate the patient and determine if they really need to be held. So it's kind of like a check on our power, so that we're not just holding people who don't need to be held. We don't try to do that, but that can happen, and I think that's one of the checks kind of on that is this. So they'll come in within 24 hours. If they determine that the hold was appropriate, then they will basically like uphold the hold, so to speak. And the hold then lasts for an additional 2 days, and then a second DE, designated examiner, comes from the state to then reevaluate the hold for a second time. And if that hold is then upheld, then the hold then escalates up to a court. So then the patient then has a court date that's scheduled, where the hold then is evaluated by a judge at that point, to determine if the patient needs to be held or not. So that's kind of the progression of the hold. My first patient that I had was already on a hold and had already been evaluated once by the DE when I arrived on the unit. And when I was taking care of them, they got their second DE, and it was kind of a cool opportunity because the DE, after the fact, called our little resident workstation, and we got a chance to chat with them. And they were kind of like 50-50. They were like, well, like, there's aspects that, legally speaking, where I'm like, I don't know if they quite meet criteria, but they said this or this that was concerning. Like, what are your thoughts? And, it was cool to be able to chat with them. And I was like, have you had a chance to talk to the spouse about this? Because when I was talking to the spouse, they were saying, this and this and this, and these concerns that they had. So it sounds like the patient really isn't, like, they're improving, but they're not really in a space where they feel comfortable or safe from the spouse's perspective. Additionally, like, these are on my interview, like, this is how the patient was kind of interacting. These are the types of behaviors that they're having still. I still think that they're suboptimally controlled. I was pulling that they would uphold the hold, that they would keep it on, and they did. And so the patient, because that was their second one, they had a scheduled court date, and he met with the judge, which is like a online Zoom. So he did it from the hospital. And the judge did drop the hold at that point. He was at a point where we had stabilized his symptoms where he didn't meet like legal criteria to be placed on hold. But the patient actually ended up admitting himself voluntarily to complete the course of the treatment, which is quite common. And it's something that, hopefully the patient starts to understand, or especially if they're getting benefit, like they're seeing, they're feeling better, and they're like, yes, do I legally need to be here? No, I could leave, but I'm receiving benefit here, and we're still trying to get my medications in a good spot. I'm just gonna, if it's cool with you, like stay here. So they voluntarily stay, but they could leave at any time after that point, once they're past that. So that's always kind of the balance that you're playing, is like, is my patient, if they were to leave today, where would they be at? A lot of times they will stay voluntarily, but there are times where a patient wants to go and they really are a concern, and so you place a hold. And then there's some people where they're a concern, but they're not enough of a concern to place a hold, and they want to go, and that's their choice, and you have to let them go. And you wish them the best, and you try to set up outpatient psychiatric care, and you do the discharge and try to set them up with the resources to be successful. But, there is a little bit of a line there of a patient being able to make that decision for themselves versus like you as a physician saying this person needs to stay here, or I would like it for this person to stay here because I think they're getting good benefit and they're improving, but legally I can't hold them here. So anyway, understanding that system, I think, has actually been really, really cool, really interesting. I don't know, it's just been interesting to learn about. And when you're placing holds on people, it's kind of scary, and it's also kind of cool at the same time. Like, it's all about just trying to do what's best for the patient and also their peers around them, especially if they are very violent or agitated or saying things like that, where it's just different. It's a different type of medicine. It's just I think really, really cool. So hopefully that gives you a glimpse into some of the inpatient psychiatry that I have been doing over the last week and a half. Next time I chat with you, I'll talk more about consults and about what's called BHAC. So I'll save that for next time. And I also should be starting at the prison by then too. So I will have lots to chat with you about then, but hopefully that gives you a glimpse of what inpatient psychiatry is like. So I hope you all have a great week yourselves, and I'll talk to you next time.